Okay, thank you very much. We turn now to board committee feedback, and we have feedback from 4 committees. Audit and Risk to start, please.
Thank you, Malcolm. The paper I'll take as read. I think there's a considerable amount of work ongoing. The system of internal control and the key components of that, the Audit and Risk Committee was assured were in place. There is considerable work to be done. December is an important update for us on major programs on cyber and data security and on a number of other factors of the internal control system. But the team are doing a good job. The only thing I would highlight, Malcolm, is that the board is asked to approve a number of changes to standing financial instructions that were considered by the committee and are recommended. They're summarised in Appendix A.
Thank you, David. Any comments, queries for David?
All difficult questions to the Acting Finance Director.
Shall we avoid that temptation for the moment? May I ask the board if they're content to endorse the revised standing financial instructions and to receive the report? Thank you, David. Back to you then for commissioning committee.
2 commissioning committees, the first of which there is a summary in the papers. I think, as ever, a full and busy agenda. I would point to the various items, particularly the assurance process report on 1415, where clearly the environment is considerably more challenging, but also I think it's important to recognise that we also upped our standards and our expectations of what we would wish to see from CCGs as we continue to try and drive up aggregate system performance. I would highlight for the board the commissioning intentions for urgent care, incorporating NHS 111 and out-of-hours service. It links to what Bruce was talking about before. Considerable and I think very encouraging work across the commissioning system, including NHS clinical commissioners, NHS England, urgent care group and clinical senates, to come up with a set of commissioning intentions that can then be used extensively across the NHS. Worth noting that NHS 111, for notwithstanding criticism, is actually delivering extremely well and is dealing quickly and professionally with considerable numbers of cases that would otherwise go to A&E and therefore relieving pressure. The key thing I would point is the need for the NHS 111, the GP out-of-hours service and the other components of delivery to be more integrated, and that's what the Commission intentions set out to do. I think the other point of note is that we have agreed the commissioning responsibilities for health services for people in police custody to move from local police forces to NHS England. I think we would hope, anticipate and expect considerable improvement in the services to a group of people who are probably not as well served as we would hope at the moment. So I think that's important. I'll take everything else as read. On the second commissioning committee, which was held this week, the topic was much more on the forward agenda. Therefore, we reviewed the commissioning strategy that we have been working on, work in progress, but is really trying to set out what are the capabilities, tools, and the changes that need to be made to support the forward view and how commissioners can play a key role in implementing that. And the second key agenda item linked to that was therefore how can we the progress on the new models of care, and in particular the enablers that need to be in place to allow those to be scaled quickly and there are considerable amounts of work going on across everything from incentives right the way through to workforce, right the way through to contracts. Would be three that I would highlight as all being areas where, with the vanguards co-producing, there is considerable work going on that will ultimately make, I think, quite significant changes to the commissioning landscape toolkit to be able to make the new models of care come to reality across a broader set of the population. Those, I think, are the key things I would point.
Thank you, David. Questions, comments for David? I mean, I'm conscious always that an enormous amount of difficult and complex work is done in committees, and commissioning committee under David's chairmanship is grappling with issues of great complexity. We're able to take assurance as a board that these are issues that are being reviewed both with the executive team and also using our non-executives in committee mode. So may we take David's report, and thank you for that. Investment committee, Moira. Thank you. Noel, specialised commissioning.
Well, perhaps in the absence of any formal written minutes or report back, should I just give a quick flavour of the sort of topics we've been looking at? So we have really three categories of topic in the last meeting over which we assure, explore and try and look forward to the future horizon in Specialised. And in the assuring category, we received an important paper on the delivery network for hepatitis C, in which the clinical teams have put a huge effort to ensure that we're ready to roll out in an efficient and targeted way. And that was a very important piece where the committee assured the work that had been done to create the operational delivery network for Hep C. In the Explore category, we took the opportunity to investigate the cost of drugs and devices, which in Specialised is one of the inflationary trends we've identified over the next 5 years that's going to impact, is impacting and will impact widely. And that was an important and correct discussion for us to have, to look at ways in which we can moderate some of the upside financial risk over future drugs and devices. And thirdly, in terms of looking at future horizons, as I mentioned in my last report to this board on our commissioning intentions prioritization framework, an excellent piece of paper came forward to look at how we might improve our methodology for commissioning intentions in 16-17, which we committed to do, having put in place an interim methodology for 15-16. 6 options are on the table. They're based on significant academic and international work. And without promising whether we will actually be able to adopt any of them, we're going through a process of due diligence to ensure that we have really shaken the trees to see if our commissioning intention process can be improved. And finally, we looked at patient and public voice mechanisms and the architecture by which we get public engagement in the crucial area of specialised commissioning. Plays very much into Tim and Victor's report generally. And while we're quite pleased, I suppose, with the way in which the architecture is working, there are certainly areas which we're going to improve for the coming year, and we will align with Tim and Victor's work on that more generally. So that's a flavour of the topics we covered.
Thank you very much, Noel. Any questions on that? Just to add to that, that earlier this week we had one of our quarterly formal accountability meetings with the Secretary of State and Health Ministers, at which we put forward our work on specialised commissioning as an area to demonstrate how we were developing policy, how we were bringing the budget under control, and the assurance to the board that is given through the work of the Specialised Commissioning Committee. Okay. Well, thank you very much for that. That brings to an end the formal business of the board. Could I just ask whether there's any other business? I just have a couple of items. One is to let you know that at this meeting last year we resolved as a board, in accordance with our freedom of information framework, that we would publish the agenda and minutes of our private board meetings 1 year on automatically, so that by the end of this month, last year's November private board meeting minutes and agenda will be going live on the web, and that will then become a rolling programme after that. Secondly, to report that the date of the next meeting will be on the 17th of December here in London. And thirdly, I'm going to invite the Chief Executive to perhaps give us a summary of takeaway messages from this morning's meeting.
Okay, thank you, Malcolm. Well, rather than summarising what we've discussed, I think it might just be worth for 20 seconds or more just talking about some of the things we haven't discussed, because obviously our agendas are strategic and forward-looking, but the reality is that a lot of time from the national directors, myself, our teams is actually spent on operational realities in the health service right now, working with NHS Improvement, the Department of Health and others. So Barbara has touched on a lot of the work going on around RTT, cancer diagnostics, ambulance readiness, mental health crisis care, the work that Jane's doing on learning disability care and treatment reviews to try and ensure that those patient-facing standards are in place. The junior doctors dispute, obviously Barbara and Bruce are acutely involved in the readiness preparations in the way that Barbara described, just as we were when there was a dispute in the ambulance service a year ago. So that is going to be a source of immense operational focus over the next 3 weeks or so, leading into, of course, this complex time of year when we move into the winter planning and operational delivery, where we move into kind of a real-time oversight process, and we will be this year setting up a joint winter command structure with NHS Improvement. There are continuing pressures clearly in general practice, and so a lot of the work around getting the investment in the new GP premises, the fill rates on the vocational training scheme, the co-investment we're making in community pharmacists, huge work there that we should acknowledge and thank our staff for doing. Many parts of the country are, as part of a response to the financial pressures, involved in service redesign and reconfiguration. So enormous amounts of ongoing work by our local and regional teams, things like the Manchester emergency surgery redesign, or anytime CQC goes in and identifies a problem in a provider, that gives rise to joint work by our local teams there, which is important and a great source of local focus. And obviously the backstory on all this, the huge financial pressures that we talked about earlier on the provider sector this year, which we, together with NHS Improvement, we talked about, are that's part of the reason we're so determined to have a financial settlement for the NHS for next year and beyond that will enable us to put a year of stabilisation and recovery into the sector, easing those deficits out as we take the action on agency staffing, the Carter agenda, get that trajectory right. So really that was more than 20 seconds, but that actually I think is just to kind of underline the point that although we're talking here typically about these strategic and forward-facing agendas, actually we are also intimately aware of and deeply engaged in the pressures and the realities of helping the health service work.
Thank you, Simon. I will now invite the board to pass the usual motion about resolving going into our private business, and I declare the formal meeting of the board to be closed. Thank you.